With the undeniable rise of violence and assaults towards our healthcare staff and first responders, it's time to prevent, protect, and preserve those who take care of us. Make stethosleeves the first choice in protecting our frontline workers.
This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffee, who is a paramedic and communications professor.
Today we're talking about what is epinephrine and why do we use it? And some of us already know that epinephrine is also known as adrenaline. It's this medicine that we use during emergencies that helps the heart pump stronger and raises blood pressure when someone's heart has stopped or it isn't working well. And it's been used successfully for heart problems caused by medical issues like heart attacks. And it's just that we don't know much about how well it works for other types of heart emergencies, like trauma-related cardiac arrest. And when we think about traumatic cardiac arrest and what happens when someone's heart stops after a major injury, like a car crash or a gunshot wound or a serious kind of fall, these are injuries that cause problems like losing too much blood, right? We remember that as hypovolemia, or not getting enough oxygen, and we remember that as hypoxia. And also the damage to the organs. That's what happens, when we are not getting blood flow to the right places when the heart stops beating. So the question is whether epinephrine works in these cases, because it might not help, or it could even hurt when the heart stops because of trauma. It's like the thought is we always want to be thinking about what treatments that we're providing, because these things are able to help us look at how do we advance healthcare better? How do we make things better? We don't ever think in science that we have the right answer figured out 100%. We always want to be able to study and make sure. And so I do spend a lot of time just searching for what's out there and what's cool. And I found a recent study called Epinephrine in Pre-Hospital Traumatic Cardiac Arrest: Life-Saving or False Hope. And this thing was published in Pre-Hospital Emergency Care, February 2025. I wanted to talk about it. So this study looked at data from over 1,600 trauma patients who went into cardiac arrest outside the hospital. And it found that using epinephrine was linked to lower survival rates, especially in patients with blunt trauma like car accidents. And for patients with penetrating injuries like stabbings or gunshot wounds, the effect of epinephrine on survival rates was less clear, but still not beneficial. So based on these results, epinephrine may not help, and it could even harm patients in these cases of traumatic-related cardiac arrest. All of this could suggest that our treatment protocols, as we see them today, may not be the same way in the future. So today we have the lead researcher from the study with us. Welcome, Dr. Witt. Are you there for us?
I am. Thank you.
Oh, gosh. Thank you for being here. Can you just first tell us about yourself so that we can all get to know you?
Absolutely. I'm a trauma surgeon and researcher here at a level 1 trauma center in Loveland, Colorado. I attended medical school at the University of Michigan, and that's where I first started doing trauma research. I did my general surgery residency at the University of Washington in Seattle, where I spent 2 years as a T32 funded research fellow and also received a master's in public health and epidemiology. I went on to do a trauma and critical care fellowship at Denver Health and the University of Colorado. I'm board certified in general surgery and surgical critical care, and I currently practice trauma, surgical critical care, and emergency general surgery, and I'm also engaged in trauma outcomes research.
I'm excited that we're able to dive into this topic together. And first, tell us what motivated you to do this study on epinephrine.
Sure. Well, in medicine, we try to practice based on evidence, and sometimes we're practicing based on extrapolated data or at times even feelings. When traumatic cardiac arrest occurs, these are really high stress situations, and we all want to do everything we can to save our patients. Anecdotally, that frequently involves epinephrine administration, extrapolating from ACLS guidelines. However, a lot of us are of the opinion that this may not provide benefit, and there's some limited but existing research supporting that hypothesis. So, we started this study in order to really try to have an evidence-based quantitative answer to whether this was something that we should be utilizing in our patients or not.
Okay, because I thought that, well, all people who get CPR receive epi, right? So how did you find some people who did not get any epinephrine during this process so that you could compare, make comparisons for your study?
Yeah, so there's actually quite a lot of trauma patients who do not. People who are receiving CPR for medical arrests should get epinephrine. That's the ACLS guidelines focusing on early defibrillation, high quality CPR, and pharmacologic support with epi. ACLS was designed with a focus on medical patients, not trauma patients. And many of the trials that studied epi for cardiac arrest explicitly exclude trauma patients. There was a 2018 randomized trial of epi for out-of-hospital cardiac arrest published in the New England Journal of Medicine that did show benefit to epinephrine, but only 1.5% of the 8,000 patients included sustained trauma. And so there has been a little bit of research looking at what current practice for traumatic arrest is. There was a study a little while back that looked at EMS protocols publicly available that pertain to traumatic arrest. At the time of that study, there were 35 states with publicly available EMS protocols, and 16 of those states had a protocol specific to traumatic arrest that outlined specific management steps. Narrowing that down further, 6 states had recommendations regarding epinephrine specifically, and 3 of those were in favor and 3 recommended against it. A separate portion of the same paper looked at the National EMS Information System database, NEMSIS, which is a pre-hospital database that U.S. EMS agencies can voluntarily submit data to. And it's a program of NHTSA. And they looked at the frequency of several different pre-hospital interventions and found that in the cohort that they were able to evaluate, the epinephrine was used in about 60% of traumatic cardiac arrests in that data set. So there are a lot of patients out there who are receiving this, and there are also a lot of patients out there that are not receiving epinephrine in the context of traumatic arrest.
I wanted to ask you, with all the data that you collected from, well, 7 different trauma centers over 6 years, I think it was, I was just wondering, how did you ensure that you could do some kind of consistency in that analysis so that, the information could be balanced out? and that you could work with it.
Absolutely. Well, one of the nice things for the purposes of this type of study is that traumatic cardiac arrest and the interventions available have not changed drastically over the time course of the study. So there are not any real temporal factors to weigh in. Certainly, institutional protocols may change over time, but overall, by and large, the interventions that we're using on these patients are similar over time. And then we use standardized data collection tools across all the sites and ensure that everyone who was abstracting data was well trained. The data were coalesced and reviewed by a single person, my co-author, Dr. Schatz. And then I performed a number of analyses once we'd coalesced into a single data set to ensure that abstraction appeared consistent across centers.
Okay, so for data nerds out there, can you tell me a bit more about those analysis, like the multivariable analysis and the time to event analysis, so we kind of better understand the inner workings of your study?
Sure. So multivariable analyses are essentially intended to address differences between our comparison groups, so between the epinephrine group and the no epinephrine group, with the goal of addressing confounding variables. And since this was a retrospective study, not a randomized controlled trial, there was potential for a number of confounding factors that could influence our results. So we used established statistical techniques to determine which variables to adjust for. And this manuscript ultimately included age, sex, mechanism of injury, and initial heart rhythm. That said, there can always be potential for residual confounding, particularly as it pertains to variables that we don't have information about. One relevant example in this study would be the duration of the cardiac arrest itself. And then time to event analyses are typically known as survival analyses or Kaplan-Meier curves. And so this is really something that's looking not just at whether a certain outcome occurred, but at whether that happened quickly or slowly, and what was the temporality of that. And so a multivariable analysis may try to answer the question of whether survival was higher or lower in the epinephrine group. Time to event analysis will evaluate whether survival was longer or shorter. So they are similar but different. And, in our paper, we demonstrated lower survival in multivariable analyses amongst the epi cohort, and overall blunt, a combination of blunt and penetrating trauma in younger patients aged less than 18 and those with initial shockable rhythms. We did not observe a significant difference in survival amongst the penetrating cohort or the cohort aged greater than 65. Both of these two had very wide confidence intervals. And then in our survival analysis, we have determined that patients receiving epinephrine had poorer cumulative survival in the overall cohort and either poorer or similar survival in the kind of mechanism-specific cohorts, again, indicating that epinephrine does not seem to make patients better and that overall this occurs early.
Okay, so can you tell me more about this differences now when we have outcomes between blunt trauma and penetrating trauma patients? Like, tell me more about how the differences are.
Yeah, so we're trying to, assess, life-saving maneuvers in patients who are injured in potentially very different ways. And so it is, I think reasonable to hypothesize that patients might respond differently. What we saw was a much wider confidence interval amongst our cohort with penetrating trauma compared to the blunt trauma cohort. And so a wide confidence interval essentially means that it is statistically harder to answer the question of where the true answer lies. And so if you think about what a penetrating injury is, it's a focal injury in which anatomic variability will greatly influence what the patient is dying from. And so a gunshot wound to the heart will cause arrest very directly. A devastating gunshot wound to the brain may affect that patient's hemodynamics and trajectory very differently. Likewise, massive bleeding from a gunshot wound to somewhere in the abdomen, impacting the cava or the aorta or iliacs or other major vessels will lead to a sort of different pathophysiology in response to injury. And so you can kind of understand why there may be a lot more variability in what those patients look like and how they present compared to a blunt trauma cohort, which will maybe just be a little bit more homogeneous with respect to what is causing arrest.
Okay, so Dr. Witt, we know now that, epinephrine appears to be less effective or even harmful in these trauma cases. So why is that? Because my imagination says, okay, the physiology, well, the way it works is that there's no blood left. So what we're doing is just introducing epinephrine to make the heart be stress even more about trying to find blood that's not there. Tell me what you're, that's my shot at it. Tell me what you're thinking.
Yeah, I think, there's a few different reasons why epinephrine may not be as effective or even harmful in these cases. And so if you think about a medical cardiac arrest, we're usually, not always, but usually thinking about an electrical abnormality that's leading to life-threatening dysrhythmia, whereas cardiac arrest from trauma may result from severe hemorrhage, hypoxia, or mechanical impairment of the heart function. So things like tamponade or tension physiology. And so, I think point number one would be that we see vasoconstriction and tachycardia as normal early compensatory processes for progressive blood loss, hemorrhagic shock, that's mediated by the sympathetic nervous system, the renin-angiotensin-aldosterone system, and endogenous catecholamines. And so giving additional exogenous epinephrine to further these mechanisms may not really provide much additional benefit. We may be kind of hitting a ceiling, and there's some basic sciences studies that support that. Number two is, I think, in part what you're getting at, which is that myocardial survival is dependent on coronary blood flow and oxygen delivery. And so if we have a patient with severe hypovolemic shock and subsequent traumatic cardiac arrest, we are seeing very minimal coronary blood flow. And then adding exogenous epinephrine may induce further tachycardia, and that may increase the myocardial oxygen demand with no ability to supply that demand. There's some animal studies that suggest that exogenous epinephrine may worsen or at least not improve myocardial function. Another facet is that epinephrine may be arrhythmogenic, which certainly doesn't help if we have a heart that is struggling to provide blood to the tissues.
Yep.
There have been some animal studies that suggest impaired cerebral perfusion and or oxygenation in the context of epinephrine, although there's some conflicting literature there. And then I would also say that if epinephrine is helping to establish and raise a blood pressure, that higher blood pressure may in fact perpetuate bleeding. And if the source of bleeding hasn't been addressed, this may really be counterproductive. So, all of these are to say that epinephrine may not be that sort of low risk, high reward intervention for a trauma patient that's in extremis. And it would also suggest that even if epi were to assist in achieving ROSC, or return of spontaneous circulation, that this may not necessarily bring us closer to the actual goal endpoint of survival.
So do you think further research on some of these other treatments for cardiac arrest is really needed? Because what would you prioritize? Like now that we're able to see that some of the things that we've been doing for years and years have just not maybe been the best choice. When we are learning more and more right now, what do you think people should be doing research on for this area?
Well, I think from a clinical perspective as well as a research perspective, it really appears that early definitive care and hemorrhage control needs to be the priority. There's been other studies of traumatic arrest that even show that chest compressions in this context may not really provide much benefit. And so these patients need to be at a place where we can achieve hemorrhage control, where we can, address any of the other etiologies that are leading to arrest, attention pneumothorax, tamponade, et cetera. And so I think really, as far as trying to move the needle at a large scale, the goal really should be hemorrhage control. We are seeing increased utilization of pre-hospital blood products and whole blood. And I think that is really a big opportunity, really these things that are able to address bleeding, which is the thing that is, usually what the patient is dying from. So I think, treating with kind of extraneous medications is probably, not very beneficial. And what we really need to do is focus on what is the patient dying from and how can we support their physiology or reverse that.
Yeah, and so many times it's just not so possible to do emergency surgery out there in the street. What advice would you give people who are young researchers interested in studying EMS, trauma care, or medicine? What do you think new researchers need to hear from you right now?
Yeah, so get out there and go do it. There are countless unanswered questions out there, and we always want to seek to answer those questions so that we can provide the best evidence-based care for our patients. I think many researchers, myself included, are always glad to work with trainees. I have a number of medical students working with me, for instance. And so really trying to teach research and teach the process early. I think it's really important to do research the right way, starting out with a hypothesis and a clear thought process about how we should answer a question. We don't want to just be mining data to find some significant p-value in the mud, because that's not good science. That's not what we should be basing patient care on. And so there are a lot of different training pathways out there for people who are interested in doing research and really making sure that you are achieving the training you need and surrounding yourself with the people to help make sure that your methodology is appropriate and correct. And then I would also say that collaboration is very important. So collaboration across specialties, across institutions is very useful. In part, it will bring us well-powered studies with large N's, but it will also bring additional perspectives and ideas to our work. And, at the end of the day, our goal is to change lives and to make patients survive and make their lives better and allow them to go on to live fruitful lives with great quality of life. And so it sounds very pie in the sky, but it's achievable. And, there's a lot of work to be done. And there always will be as we adjust practice and, consistently evaluate and reevaluate our practices.
Well, you're one of those people, and I thank you so much for doing that job, because you're not just doing it. You today have shown us how research can be fun. And it's fun because,
You like it.
a lot of us are able to understand and see like what you just figured out and how you figured it out and how it applies to a role that, we do as paramedics in the field. And so, again, thank you for being here, and it's been great. I look forward to seeing you again in the future.
Thank you for having me.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but, I don't care how much skill you have. There's very few people who would be able to not say, oh my gosh, I need help. And then all of a sudden someone shows up.
With a badge.
Yeah. And right. You think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out, because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chapleau from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month, free for your review on our website at iphmi.com. and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here. and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.